Everyone. I hope you all had a refreshing tea break. Now we are going to start with our next session, which is on a very interesting topic, that is endocrine tumors. To guide us through the session, we are honored to have our esteemed chairpersons, Professor Sylvia C. Estrada. She is Division Chief, Pediatric Endocrinology and Metabolism, UPCM, Philippine General Hospital Secretary, APIS.
Oh my God,
And her areas of interest are inborn metabolic disorders, newborn screening, clinical endocrinology, growth, and DSD. Now, our second esteemed, I welcome you, ma'am. Our second esteemed chairperson is Dr. Rakesh. He is Professor Pediatric Endocrinology and Diabetes Unit, Advanced Pediatric Center, PGIMR Chandigarh, and his special interest is in childhood diabetes, and he has been awarded with very prestigious awards. And he is having more than 100 publications and book chapters and more than 40 presentations.
Yes.
I welcome both of you. Without further ado, I now invite you to start the session.
Yes.
Thank you.
Yeah. So thank you and good afternoon, everyone. Rakesh, you'd like to greet them?
Thank you, everyone. I hope you are enjoying the hospitality and the cuisine we are offering. So without wasting much of time, Dr. Sylvia will be introducing the first speaker.
Yes. So good afternoon again. So it is my honor and pleasure to introduce to you Professor Wasim Shematili, who is the clinical director and division of the Division of Pediatric Endocrinology. He has been introduced yesterday, but very briefly, he is with the UPMC Children's Hospital, Division of Pediatric Endocrinology, a co-author of more than 120 articles and chapters covering different aspects of pediatric endocrinology, including 80 original research articles focused on the long-term health outcomes of childhood cancer survivors. So Professor is going to speak about growth hormone treatment in childhood cancer survivors, the specific aspects and safety considerations. Professor?
Thank you so much for this very kind introduction. And thank you for the scientific committee and the organizers for inviting me. This is really a huge honor for me. And I'm really also very grateful for the audience and for sharing with me my interest in childhood cancer survivors. I don't have any conflicts to disclose. And so the learning objectives for this session are to describe the basis for the concern that endocrinologists and physicians at large have regarding the safety of growth hormone in patients who were treated for cancer, is also to review available data from large follow-up cohorts that try to investigate questions pertaining to growth hormone safety in this population. I will then focus on current practice guidelines or consensus recommendations related to this area, and specifically to recommendations from the Endocrine Society and also from the Growth Hormone Research Society, and to wrap up by discussing some areas for future research. My presentation will not be very long because I anticipate that we will have a lot of questions, so I would want to save time for Q&A. As we discussed yesterday, growth hormone deficiency is really among the most common endocrine complications observed in childhood cancer survivors, especially those with history of tumor growth in the hypothalamic pituitary region or radiation to the hypothalamic pituitary region. And in this instance, the deficit in growth hormone might happen in a delayed fashion as a late effect. And in this graph here, which I had detailed yesterday, you can see that the prevalence of growth hormone deficiency in a large cohort of childhood cancer survivors overall was 22%, but also it exceeds 80% in individuals who had hypothalamic pituitary involvement in terms of tumor or radiation. So a very common problem. And so why is giving patients who are growth hormone deficient but have a history of childhood cancer an area that has raised concerns related to safety? So that we can look, first there are some experimental models that have resulted in concerns as to whether growth hormone is safe in general. And these pertain to in vitro models where it's been shown that overexpression of growth hormone increases the proliferation of malignant mammillary cells, and that this is a direct effect of growth hormone independently from IGF-1. IGF-1 itself has known properties as mitogenic, proangiogenic, anti-apoptotic, leading to the promotion of tumoral growth in vitro model as well. And interestingly, these actions seem to be inhibited by IGF-BP3. These models were also furthered by transgenic animals, where in tissues where there was a targeted overexpression of IGF-1 or of growth hormone, there's been a higher risk observed for tumor progression or development, as well as metastases, a risk that is also decreased when there is inhibition of growth hormone or IGF-1 and overexpression of IGF-BPs. So it's really, these experimental models have made people pause a little bit about how safe it might be to give growth hormone to individuals who are at risk. Now, there are also some population data that have fed into this concern related to the use of growth hormone. So there has been a known association that's been, described between cancer risk in individuals who have increased growth hormone or IGF-1 secretion. So this is based on models from patients with acromegaly. There are also some data that are more population data related to correlations between higher IGF-1 levels and certain cancers in the general population. So acromegaly, it's been reported that patients have higher risks for colon cancer in particular, and also thyroid cancer. As far as the population study has been shown, there have been some weak associations between IGF-1 levels in the upper ranges and higher risk of breast, colorectal, and prostate cancer in the general adult population. And these issues have really reinforced concern about the treatment with growth hormone in at-risk populations, which include childhood cancer survivors. The reason being that childhood cancer survivors already have a higher risk than others of developing malignancies, and in particular, subsequent malignancies, of course. In the childhood cancer survivor study, so as many of you know or might know, childhood cancer survivor study is a very large North American cohort composed of individuals who receive treatment for childhood cancer in any of the participating North American hospitals. And it's really a self-reported cohort where people fill out questionnaires and send back related to their different aspects of their lives, healthcare utilization, diagnoses, etc. And what has been shown by the CCSS is that in a cohort of 14,000 individuals, after a median age of 32 years, so people who, many among whom were adults, 9.3% experienced a second neoplasm after having been diagnosed with their original neoplasia or tumor when they were children. And that risk includes non-melanoma skin cancer, breast neoplasm, meningioma, which is not really a malignancy, but it is a tumor that is really correlated to treatment with radiation to the brain, thyroid cancer, soft tissue sarcoma, and various central nervous malignancies. Among those who developed a second neoplasm, even more concerning, 28% went on to develop a third or multiple other neoplasms in the subsequent 20 years. So this is a high-risk population when it comes to the risk of development of secondary malignancies. And the reasons are probably that there is an underlying genetic predisposition which led to the initial cancer, probably. But then there is also the normal tissue injury from cancer treatment, and in particular radiation, which play a role in increasing the risk substantially in these patients. And so you put that together with that growth hormone deficiency affects up to 22% of childhood cancer survivors, and many of those who have had treatment for CNS neoplasia, you can see why this is a significant concern. One that many among us who work in late effects and endocrine sequelae really have to have conversations with families about pretty much every day. So what do we know about growth hormone treatment and cancer recurrence in childhood cancer survivors? So multiple cohorts and multiple treatment registries have really shown that treatment with growth hormone does not increase the risk of having the risk of having a recurrence of the same cancer. So the way I describe it to my patients, the same cancer coming back. So we know that treatment with growth hormone doesn't cause that to happen, is not associated with that. And this is also based on various reports, but specifically also from the childhood cancer survivor study, where the relative risk was 0.83, and it did not really reach statistical significance. And in the same report, and in multiple other reports, it's been shown that treatment with growth hormone does not increase the risk of death from cancer in people who were treated with growth hormone versus those who were never treated with growth hormone. So when patients ask me, is it going to cause the same cancer to come back, or is it going to cause mortality in my child? These are questions that I find easy to answer because of the data that we have. What is a little bit more complicated is the question of secondary neoplasia. So data on treatment with growth hormone and secondary neoplasia have been concerning for a higher risk in individuals who receive treatment with growth hormone compared to those who did not receive this treatment in the childhood cancer survivor study. So the first report was by Dr. Sklar back in the early 2000s, where they showed in this large cohort that the relative risk of developing a secondary neoplasia was multiplied by 3 in individuals who received treatment with growth hormone. And this included 15 individuals who developed meningioma. This was really the predominant secondary neoplasm. There were 6 patients. Osteosarcoma and soft tissue sarcoma. And it was a risk that was driven by meningioma, which again is a tumor that is very, very closely related to treatment with radiation to the brain. In an updated report from the same cohort with a little bit more numbers and more follow-up in 2006, it showed a slightly lower relative risk, but still a significant association. These reports confirmed lack of association between treatment with growth hormone and cancer recurrence, primary cancer recurrence, or mortality from treatment, increased mortality associated with growth hormone. Several studies since then, and these reports really changed the conversations related to growth hormone. And so several studies followed trying to specifically look at the association between treatment with growth hormone and secondary neoplasia. Most of these studies did not show this association, specifically those that looked at tumors related to the central nervous system. And this is why this continues to be an area of controversy. What is also difficult is that the work that was done in the childhood cancer survivor study cannot be really easily replicated in some of the growth hormone registries because we are lacking a control group of patients who were not treated with growth hormone and had malignancy. These registries, such as the SAGE study, generally have patients who are treated with growth hormone in general, and then you're looking at the different complications. You don't have a control group. And so we can only infer from these studies some of the data that we need. For instance, there was a recently published paper from SAGE, which is a registry from Europe, that showed that there was no correlation between meningioma related to radiation and dose of growth hormone or duration of growth hormone. Which really indirectly indicates that there's probably not a relationship. But this is, these data can only be inferred from. And so when experts in this area met in the framework of the Growth Hormone Research Society in 2022, the statement was that the specific effect of growth hormone on secondary neoplasia is probably minor in comparison to host or tumor-related factors. And this is the key element in my conversations with patients, which is, treatment with growth hormone may hypothetically cause a higher risk of something else happening, so a tumor happening somewhere else in the body. But this is something that's not been universally shown. And in reality, the risk that's already conferred by the previous treatment with radiation of the brain is so much higher than by whatever growth hormone could add. That this is really where our discussion should be. But these are complex discussions that we have every day, and I think we might be spending some of our Q&A on these. So what are the Endocrine Society recommendations? The Endocrine Society recommends offering growth hormone to childhood cancer survivors with confirmed growth hormone deficiency because we know that it is safe in this population. We generally, and again, this was experts agreeing, there are really no data to show that this should be the practice. We wait until the patient has been 1 year disease-free, completed treatment for malignant disease before initiating growth hormone. Obviously, with all the shared decision-making discussions with the oncologist, the patient, their family. Now, survivors who have chronic stable disease, but who may never be disease-free, for example, patients who are treated for optic pathway tumors, this is where we also have discussions with the family and with the oncologist to discuss the appropriateness and the timing of the growth hormone replacement. The management of growth hormone replacement in these patients tend to follow a similar approach than the one that's used with the non-cancer patients. I will say that I still tend to be conservative, where I keep an eye on the IGF-1 levels intermittently to make sure that they do not rise above physiologic level, where in most instances people check the IGF-1 level only once a year. I might check it a little bit more often to be sure, especially as we reviewed yesterday, some patients, including those who received radiation to the spine, may not respond very well, so you have to be very, very careful about not treating supraphysiologically for no benefit in these patients. So I will say keeping an eye on IGF-1, making sure that the patient is responding to treatment are really elements that are so important in this population. Now, the Growth Hormone Research Society expanded on these recommendations a few years later, because it also had experts in adult endocrinology who joined the group. And it tried to fill some of the questions that had been left open by the Endocrine Society guidelines. Again, reinforcing that the timing of the initiation should really be individualized with shared decision-making, that it's not written in stone that it has to be 1 year. This period may be as early as 3 months in children with radiologically proven stable craniopharyngioma. So craniopharyngioma is an instance where it is possible to start growth hormone a little bit sooner. Again, as I discussed yesterday, in Europe, they actually don't stop growth hormone at all in these patients, which I find a little bit difficult just because you want to make sure that there is proper recovery from surgery, that there is no, it can cause some fluid retention. So I usually try to wait 6 months if I can. In adults, they say at least 5 years with a history of solid tumors such as breast cancer. Again, adult endocrinology providers worry a lot about associations that had been discussed between growth hormone and colon and breast cancer. So these are populations where they tend to be very conservative with. And again, growth hormone replacement follows the same guidelines with vigilance to avoid overtreatment. Tumor monitoring is not modified by being on growth hormone. Now, this is a piece for most of us in pediatric endocrinology, something that the oncologist takes care of. Now, in terms of adult survivors, and this was really the part that really the GRS expanded on, the general feeling among endocrinology providers for adults is that growth hormone should be offered to survivors who are deficient, because it's been associated with the deficiency untreated has been associated with adverse health outcomes, including abdominal obesity, decreased bone density, pre-frailty phenotype. There are, however, no data that specifically pertain to the benefits of growth hormone in childhood cancer survivors. A lot of this is extrapolation from adult data in individuals who had pituitary adenoma or other conditions. So recommendations are really based insofar on expert opinion, and this really should be a continued area of active research. Growth hormone replacement should be considered in adult survivors after really, again, consideration of potential risks and benefit, with, again, vigilance related to survivors who were treated for cancers pertaining to the breast, the colon, or the prostate, or liver cancer that's on remission, because these are types of malignancies that adult endocrinologists are particularly concerned about giving growth hormone to individuals who are affected of. Now, an area also that we find sometimes difficult in our practice is treatment with growth hormone to individuals who have cancer predisposing conditions. So the data on the safety of growth hormone in this context are really lacking. When you do a literature search, there is very, very little about how safe growth hormone is in these patients. And I'm talking about those who haven't developed a malignancy. So we are not in the context of survivorship yet. And it is very important that some of these syndromes are associated with short stature. So there is a specific caution that growth hormone is not to be used for height augmentation in individuals who are not growth hormone deficient and who are affected by these conditions. So someone who is not growth hormone deficient and has a cancer predisposing syndrome that's causing them to be small, this is giving growth hormone is currently, as far as expert opinion goes, is not safe practice. Now, the Growth Hormone Research Society feels that the growth hormone treatment is usually contraindicated in case of cancer predisposing syndromes, but in people who are also growth hormone deficient, but it should really be considered as an individual case-by-case situation by discussing potential risks and benefits and having shared decision-making with the family, the geneticist, potentially the cancer predisposition clinic oncologist, as well as the patient and their primary care physician. There are really no data that support contraindicating growth hormone in individuals who have a strong family history of malignancy, independently of a known cancer predisposing syndrome. And so this was really the, in brief, the different guidelines that are available on this particular topic. And as I have touched upon as I went through these slides, areas for future research are, so for how long do we need to hold growth hormone before we started in individuals who haven't been on growth hormone, or even how long do we have to stop growth hormone in individuals for whom it had been stopped because there was tumor growth and now the tumor has been cured or has been stabilized. The use of growth hormone in patients whose tumor has been controlled by continued use of targeted chemotherapy agents is also another area for research. And this is also an area where I think many among us have had experiences when we really didn't know what to do, in particular for certain treatments such as tyrosine kinase inhibitors that are known to decrease growth velocity in patients. Growth hormone and cancer predisposition, we talked about it in the context of syndromes. Really, the growth hormone risk benefit in adult survivors of childhood cancer is not something that is, is something that is sort of taken for granted by endocrinologists who see adults. But when I think about it, it's also an area of active research, because if we're looking into cardiovascular health, bone density improvement, quality of life improvement, there are probably some other ways to achieve these outcomes in adults. Whether growth hormone makes them, because we're not thinking about treatment with growth hormone until growth is completed, like in pediatrics. This is open-ended, and it is also many, many years. We don't really know the long-term benefit versus safety. So this is really an active area of research. Also thinking about it from perspective of stewardship of health resources when we think of many years of treatment with growth hormone. And then lastly, but not least, the safety of long-acting forms of growth hormone. These have become more and more used and are known to be associated with a peak of growth of IGF-1 a few days after the injection of the long-acting growth hormone. So how safe is this, and should it be navigated differently in children who are childhood cancer survivors? So in summary, growth hormone replacement prior to final height attainment in growth hormone deficient childhood cancer survivors who have achieved remission from malignancy and have been stable off treatment for over 1 year is really considered to be safe. And the benefit in terms of improving height, the benefit on function, the benefit in terms of quality of life is really considered to far outweigh potential risks associated with, you know, some of the adverse events that I discussed with you, or some of the hypothetical risk associated with secondary neoplasia in particular. The transition to adult dosing and the continuation through adult age is still an area of active investigation. Height augmentation in survivors who are not growth hormone deficient is considered contraindicated. And there is really a lot of uncertainty in all the guidelines that I've discussed, and which really rely a lot on expert opinion, which really represent also all these areas of future research that I discussed represent opportunities for future collaborative research. So these are the references that I've used for this presentation. And as I conclude for the second talk, it's important for me to acknowledge my mentors, Professor Raja Bronner in France, who taught me pediatric endocrinology, and Dr. Sklar in New York, who was my research mentor and is my lifelong mentor, got me into the world of the late effects. I also have to acknowledge and thank, and I think I've talked about this yesterday, I have a huge debt towards the medical community in India for all the outstanding, amazing colleagues I've had over the years and who have made me have so much gratitude and so much affection for your country even before seeing it. Thank you so much.
Thank you very much for your comprehensive lecture and giving us an overview on the safety. Yes, please take your seat. May we request the audience to hold on to your questions, and we'll entertain them at the end of June Q&A.
So now I'll invite the second speaker. It's my pleasure to invite Professor Vijay Sarathy, a very good friend of mine, who hails from or comes from Vaidehi Institute of Medical Sciences and Research Center, Bangalore. He's professor and head of the Department of Endocrinology there. He has been a very good student and a scholar throughout, and has got many awards, including Young Investigator Award for Endocrine Tumor Research in 2013. So I invite Professor Sarathy to start his lecture, please.
Yeah. Very good evening, everyone. I would like to thank Rakesh for the kind introduction. So I'll be briefly discussing on the multiple endocrine neoplasia. So if you look at the journey of discovery of MEN1 syndromes, indeed it started almost in 1903. But though the concept of multiple neoplasia existed or introduced in 1903, a clear description of the first multiple endocrine neoplasia, that's a MEN1, was given in 1954 by Wormer. 5 years later, the SIPL gave MEN2 description. But however, their underlying genetic mechanisms remained undiscovered for another 40 years. So they got to be discovered as MEN1 gene and red gene in 1990s. So even the beginning of the century hallmarked introduction of one more MEN syndrome, that is MEN4. That's because of mutations in CDKN1B. Whereas in 2020s, we are going to witness one more new MEN syndrome, that's MEN5, so which I'm going to talk about later. So with this journey, let's start our journey with a case capsule. We have a 17-year-old boy who presented with headache for 3 years. He also had right temporal hemianopia for last 6 months. He has pivotal arrest. So obviously in such scenarios, we always do an MRI. MRI showed a giant pituitary adenoma with a cystic component. The prolactin is sky high, almost 12,000. The patient was started on cabergoline. But since he was a young prolactinoma, we also thought of ruling out the other possible components of multiple endocrine neoplasia. So we did the calcium profile for this patient. Calcium was 10.8, which is elevated with a low normal phosphorus, and PTH was elevated. So obviously there was a diagnosis of primary hyperparathyroidism. So 4D CT was done, which revealed an enlargement of the right inferior parathyroid adenoma. So hence a possibility of MEN1 was suspected, and the patient underwent genetics, which revealed a pathogenic variant in MEN1. So we understand the fact that in patients who come to us with one single endocrine neoplasia, especially in the pediatric age group, we need to keep ourselves alert to look for other possible endocrine neoplasias. So looking at this MEN1 patient, if you look at the components that predominantly include the parathyroid involvement, pituitary adenomas, and even the duodenopancreatic neuroendocrine tumors. So when we understand the pediatric diseases, quite often we refer to the adult literature. So if you look at the MEN1 as overall, so the parathyroid tumors are the most common. In fact, they have almost 100% lifetime penetrance. So majority of them are either hyperplasias or adenomas, carcinoma being extremely rare. And if you look at the duodenopancreatic net, which is the second most common manifestation in overall, but may not be in children. But if you look at the distribution of duodenopancreatic nets, 40% is gastrinoma, whereas around 37% is a non-functional PNET, whereas around 20% are insulinomas. Whereas we look at the pituitary adenomas, they're predominantly prolactinomas, almost in around 53%, whereas in another 28%, they are non-functional, 10% are somatotrope adenomas, and a small proportion may be either corticotrope adenomas or mixed secreting adenomas. So looking at the adrenal involvement, in fact, we don't really understand the involvement of adrenals in MEN1, though we are very familiar with the adrenal involvement in MEN2. But if you look at this adrenal involvement in MEN1, it's 87% of the times it is an adenocortical non-functional tumor, whereas in around 5% it may be secreting and either cortisol or aldosterone, whereas in 7% it could be adenocortical carcinoma. Interestingly, the pheochromocytoma is extremely rare in MEN1 syndrome. MEN1 also has some cutaneous markers, very interesting to know, though they're not very common in pediatric age group, and they include lipomas, collagenomas, and angiofibromas. So with this overall understanding of MEN1, let me take you through the pediatric MEN1 specifically, those who present before 18 to 21 years of age. In fact, there are large databases which have looked at the manifestation during the pediatric age. The MEN1 manifestations do occur in and around 12 to 30% of the patients before 18 years of age, whereas among them, the PHPT is the most common, which varies from around 5 to 23%, whereas pituitary adenoma is the second most common. Indeed, unlike overall MEN1, where pituitary adenoma is the third common, among the pediatric age group, it is the second most common. And the prevalence varies from 4% to 7%, whereas for non-functional PNETs and insulinoma, the prevalence is around 2 to 5%. The gastrinoma, indeed, one of the most common PNET in adults or the overall, in the pediatric age group is extremely rare and accounts for only around 0.3% prevalence. If we further dissect into age-wise penetrance of MEN1 in the pediatric age group, if you take children at around 5 years of age, the penetrance is only 0.1%. Whereas when these children reach around 10 years of age, the penetrance is 1%. From 10 to 20 years, there is a drastic jump in the penetrance to 17%. Next important thing is that what proportion of these patients come to us with clinically manifesting disease and what proportion are actually detected only by family screening. In fact, the functional PNETs, including insulinoma as well as gastrinoma, they do present with symptomatic disease, whereas symptomatic disease is seen in around half of the pituitary adenoma patients, whereas among PHPT, it's only around 17%. On the other hand, for a non-functional PNETs, all of them were detected by screening and none of them had any clinical manifestation. Moving on to the intricacies of genetics or details of genetics, we know that the MEN1 is a tumor suppressor gene. And if you look at the pattern of genetic variants in MEN1, so that predominantly the missense variants or the frame shift micro rearrangements. Even though the missense variants predominated as an overall, but because of the more recurrent variants of the frame shift micro RGT, they account for almost around 44% of the index cases in MEN1. Then if you look at the genotype-phenotype correlation, in fact, the MEN1 is always a disease which did not yield up a very good genotype-phenotype correlation, unlike men too. But even then, when they're looking at a large databases, now there are some genotype-phenotype correlations that are emerging. One such data is the increased association, the increased frequency, as well as earlier manifestation of MEN1-related components in patients who are having a large rearrangements. This is true when comparing both against truncating as well as non-truncating variants. Another interesting finding in the same study is that it's not only against large RGTs, even between the truncating and non-truncating variants, there is a difference. The frequency of manifestations is significantly higher in those with truncating variants. But is it relevant for our pediatric population? Let's look at it. So if you look at it 20 years of age, yes, the lines are already deviating. So probably there is a significance for large RGTs and the other variants. But however, the difference between truncating and non-truncating at the age of 20 is not significant. This significance also holds good individually for PHPTs as well as for pituitary tumors, where there is a significant difference between large RGTs versus other variants. But again, there is no significant difference for truncating and non-truncating. Whereas it comes to duodenopancreatic NET, there is no significant difference based on the genotype. So we know that like all our MEN1 patients may not manifest with underlying genetics. Some definitely cases will be there which are genotype negative. But this disease, has it any significance for the pediatric age group? Again, if you look at this interesting data, none of the genotype negative MEN1 manifested before 20 years of age. So probably we need not have to bother much about this genotype negative MEN1 group in the pediatric age. So let's go to each of these main components of MEN1. So let's start with the PHPT-related MEN1. In fact, if you look at the data from our own KM, so majority of this MEN1-related PHPT were actually familial, but 75% of them were asymptomatic. Indeed, they were diagnosed because they presented with symptomatic other diseases like pituitary adenoma and PNETs. When we looked at the characteristics of PHPT in these patients, the calcium levels were lower, even the PTH levels were lower. The lesion size was also lower when we compare to other genetic groups such as CDC73 and CASR, or even the mutation negative group. So next interesting thing will be what will be their histopathology and how do we manage them. In fact, only 3 of these 8 patients underwent surgery. All the 3 had hyperplasia. 1 patient underwent total parathyroidectomy with autotransplantation. Even then, there was an hypoparathyroidism. 2 patients underwent unilateral clearance. 1 had a remission and 1 had a persistent disease. So this always remains a million-dollar question. What should be the ideal approach to manage these children with primary hyperparathyroidism and MEN1? In fact, the most recommended approaches are either the total parathyroidectomy with autotransplantation or the subtotal parathyroidectomy with removal of 3 to 3.5 glands. It's true, it's very effective to prevent the recurrence, but these 2 procedures put the children into the risk of hyperparathyroidism, and hence the recent approaches are actually favoring the unilateral clearance, probably which would reduce the risk of hyperparathyroidism. But let us understand, when we choose that approach, the risk of persistent disease or the risk of recurrence is much higher. And the other important point about MEN1 and parathyroid adenoma management, so since the rates of recurrence are higher, we not only look at the parathyroid excision, but also the thymectomy. Because thymectomy, we don't do it here to reduce the thymic NAT, but we are doing to reduce the recurrence of parathyroid recurrence, because thymus is one of the most well-known site for ectopic parathyroid and possible parathyroid recurrence. So moving on to other manifestation is the prolactinoma. In fact, MEN1 accounts for around 5 to 10% of prolactinomas. Indeed, a recent systematic review we did on giant prolactinomas, the MEN1 prevalence is around 15% in men and around 60% in females. Whether this MEN1 mutations did any difference to the response? Indeed, no. There was no difference in the hormonal or tumoral response between MEN1 patients and others. But however, there is another study which evaluated macroprolactinoma patients in pediatric age. In this particular study, there was a significant impact of MEN1 mutations on the resistance to dopamine agonist. So by this, we know that probably there may be some amount of dopamine resistance in MEN1-related prolactinomas. The third important component is insulinoma. How do these MEN1-related insulinomas differ from the sporadic insulinomas? In fact, the only difference which this study could note is the multiple lesions in MEN1-related insulinomas compared to sporadic ones. Though there was no significant difference, but what you could appreciate here is that the aggressiveness, in fact, the G2 grade was almost around 83% in MEN1-related compared to 40% in sporadic. So probably we may have to have a potential look for more aggressive tumors in MEN1. Another challenge in patients with MEN1-related insulinoma is that I already discussed, it's not only insulinoma, there is also some amount of tumors in the pancreas which are actually non-functional. So when you have an insulinoma suspected patient, how do I know whether this is a non-functional tumor or it is an insulinoma? If you do a DOTA TATE, indeed, it may pick up both functional as well as non-functional. So indeed, in our recent experience, we have found that the extended DOTA scan is very specific for insulinomas, and probably when we have a MEN1 patient with suspected insulinoma, so if you want to accurately localize the insulinomas, extended PET-CT should be used. Right, so we have different patients who are coming with single endocrine neoplasia or multiple endocrine neoplasia. So then can I know what could be the possibility of having a MEN1 mutation in a given patient? And for this, we have this scoring system. In fact, if we let us take our own index patient, which we used, who is a 17-year-old boy, so who had a pituitary tumor, who also had a non-recurrent PHPT, with sum of square score of around 160, and which yields a probability of this patient having a MEN1 mutation of around 50%. So probably whenever in dilemma, we can always consider this scoring and decide whether we need to test the patient for MEN1 or not. So next comes, how do we screen our MEN1 patients for the components? If you look at the 2012 suggestions by Thakur and Gru, they suggested to start the screening by 5 years for anterior pituitary tumors with prolactin and IGF-1, and also with MRI every 3 years. Similarly, for insulinoma also with fasting glucose and insulin. Whereas for other pancreatic tumors, they recommended to screen below less 10 years, that too with very expensive investigations like chromogranin A, pancreatic polypeptide, glucagon, and VIP, and also MRI annually. So when we have these kind of very laborious screening strategies, definitely they're going to be too taxing for our patients, especially in resource-constrained countries. So there come another set of suggestions, probably where they were a little more liberal but probably at the point without missing a large number of patients affected. And the guidelines say, of course, for insulinoma, you start by 10, but fasting glucose may be good enough. Whereas for anterior pituitary, you can delay the screening till 10 years. Whereas for other pancreatic tumors, probably there is no need to include the measurement of all those costly hormones, and you can start doing with MRI every 2 years. So with this, let's move on to another case from a different class of multiple endocrine neoplasia. He is a 12-year-old male who presented with, because his father was already been diagnosed with pheochromocytoma. That's the reason why he presented to us. So on inquiry, he also had constipation for the last 1 year, but there were no features of pheochromocytoma. On examination, you can see he has very thick lips and also some mucosal neuromas on the hard palate. Then you know what we are dealing with. So calcitonin was measured, which was elevated, whereas the metanephrines were absolutely normal. Patient underwent an ultrasound neck, which revealed a 6 mm lesion on the right side and 1 centimeter lesion on the left side. The genetic testing revealed a pathogenic variant that is at 918 codon in the red proto-oncogene. So obviously this patient underwent total thyroidectomy with a persistent disease. So what is the syndrome? It is the MEN2B. What does this occur due to? It's because of the mutations in red proto-oncogene. The mutations in red proto-oncogene can lead to 3 different set of disorders. That's the MEN2A, MEN2B, and the familial MTC. The MEN2A is characterized by occurrence of medullary thyroid carcinoma in more than 90%, parathyroid neoplasias in up to 20%, and pheochromocytoma in up to 50%. Interestingly, only 10% of these mutations are actually de novo, because the remaining 90% are hereditary, this is transmitted across the generations. Whereas it's a little different for MEN2B. Of course, medullary thyroid carcinoma is still more than 90%, though they are more aggressive. Pheochromocytoma is also around 50%, but the MEN2B lack the primary hyperparathyroidism, but they do have MEN2B phenotype in 100%. Here, majority are de novo variants, unlike MEN2A. The components of MEN2B, if you would like to scan through, they will have morphonoid habitus, like a very lean habitus. They will have mucosal neuromas. They will have high arched palate, arachnodactyly, hyperextensibility, skeletal abnormalities like kyphoscoliosis, lordosis, pectus excavatum, pes cavus. They will also have ophthalmological features like thickened corneal nerve fibers, upper eyelid eversion, as well as alachremia. Many present with constipation. Some may also present with diarrhea because of ganglioneuromatosis. In fact, some may also develop something called as a pseudomegacolon because of ganglioneuromatosis. And as I mentioned earlier, MEN2A or MEN2B, this disease we like very much, basically because there's a perfect or near perfect genotype-phenotype correlation. So if you want to understand more on this, so if we look at the 918 codon, has the highest risk of medullary thyroid carcinoma, whereas the mutations at 883 and 634 have high risk of MTC, whereas the other mutations have a moderate risk of MTC. The mutations at 883 and 918 lead to MEN2B with MEN2B phenotype. And the next is to understand the risk of PHEO. Again, the risk of PHEO is more in both the mutations associated with MEN2B and also mutations at 634 and 631, which are associated with MEN2A. If you look at the hyperparathyroidism, it occurs only with MEN2A, and the risk is relatively higher with 634 mutations, whereas cutaneous lichen amyloidosis are a rarer manifestation of MEN2A, but typically associated with 634 and 804 mutations, whereas Hirschsprung's disease, it's a true Hirschsprung disease, is associated with mutations in exon 10. So if you understand the characteristics of pheochromocytoma in MEN2A, in fact, like we did a systematic review about the genetics of pediatric PPGL, only 5% of these mutations actually are in RET, whereas the remaining are in other genes. So even if you look at the patients with MEN2A and their penetrance for PHEO by 20 years, it's only around 5%. They're predominantly metanephrine secreting, so both epinephrine and norepinephrine would be elevated, or both metanephrine and normetanephrine would be elevated, often bilateral, usually lack extraadrenal PGL, the risk of malignancy is very low. If the bilateral tumors, consider cortical sparing adrenalectomy, but if you choose that, be ready to face 3 to 10% of ipsilateral recurrence. The youngest age reported so far is 8 years for 634 mutation and 10 years for 918 mutation. So start screening by 11 years for 634 and 918, and for other variants, start screening for PHEO by 16 years. The other manifestation is a primary hyperpara. If you look at the lifetime risk, it's around 20% only for MEN2A patients. As I mentioned earlier, risk is relatively higher for 634 variants. The mean age at presentation is 40. The youngest age reported is 14 years. So it can have either a parathyroid adenoma or hyperplasia. Unlike in MEN1, where we typically consider a subtotal or a total parathyroidectomy, here it is the excision of only the enlarged glands. And if you have a patient with MEN2A, especially with 634, start screening for hyperpara by around 16 years of age. And the third component, in fact, is the most important component of MEN2A, is medullary thyroid carcinoma. Indeed, in hereditary MTC, there is a stage development of MTC. It's from normal to C-cell hyperplasia to micro MTC and then to macro MTC with metastasis. So obviously, when you want to screen for MTC, the most dependable test is serum calcitonin. But what I need to caution here is that unlike in adults where we take calcitonin of less than 10 nanogram per liter as the upper cutoff, in children, the calcitonin levels are relatively higher, especially in infants younger than 6 months. Levels up to 40 could be normal, whereas up to 3 years, it could be elevated up to 15. So use age-wise or age-specific cutoffs to screen for medullary thyroid carcinoma. In men too, so even without MTC, there may be an elevation of calcitonin, because not only MTC, even C-cell hyperplasia, which is a pre-runner of MTC, can also elevate calcitonin. Calcitonin also gives very important information about the tumor burden and also about the extent of the disease. So if the calcitonin is elevated but less than 60, we know that the disease is limited to thyroid. But if it's more than 60, then we know it's probably we have to look at the nodes. If it's more than 250, then probably we have to look at even the distant metastasis. So if you look at the MTC and how they differ from sporadic MTC, in fact, sporadic MTC account for only a small proportion of MTC in the pediatric age group, maybe around only 14%, whereas the majority, that is 86%, are actually hereditary MTC. If you look at the patients with MEN2A, in fact, MEN2B also diagnosed relatively at an earlier age compared to the sporadic MTC in the pediatric age, whereas MEN2A, majority of them are diagnosed by familial screening, whereas sporadic MTC were presented clinically in 100%, even MEN2B, 90% presented clinically. So obviously, when you're presenting clinically, they have a more severe disease and more advanced staging. So hence, their calcitonin levels were markedly elevated, tumors were larger. And in addition, a unique feature of, as I already mentioned, for hereditary MTC is that C-cell hyperplasia, but also the disease will be bilateral as well as multifocal. So these are what I mentioned earlier is the more advanced presentation in patients with sporadic as well as MEN2B, whereas majority of the MEN2A patients present in stage 1, whereas the sporadic and MEN2B patients present in stage 4. Even if you look at the long-term outcomes, the MEN2B patients have relatively lower survival rates when compared to MEN2A, and it's also true for sporadic MTC. So looking at the genetics of these MTCs in the pediatric age group, so in this nice study by Hensley et al., so if you can see that among the hereditary MTC, almost 50% had mutations in the 634, that is the most common MEN2A associated mutation, whereas 1/3 had MEN2B, that is the 918 gene involvement, whereas the remaining had mutations in various red mutations. Very interesting point in the study, though we don't know what is the therapeutic implication for this, so is that even the sporadic MTCs had somatic mutations in RET gene. So 50% of them had mutations in 918, that's the one which is responsible for MEN2B, whereas the remaining 30% had mutations in other RET mutations. Again, the interesting point of these 30% of mutations is they have never been reported so far with MEN2A or other syndromes. Probably, if at all, if any person comes to us with a MEN2A without a known mutation, we may have to consider these variants for germline assessment. So why we are so pertinent about MTC and MEN2B is basically because of their aggressiveness and also because there is a scope to address them in time so that we can improve the outcome for these patients. If you look at this international data where KM was also part of, so those patients who had a thyroidectomy before 1 year had a remission rate of 83%, whereas surgery after 1 year yielded in remission of only 15%. It's not only remission rate, even it alters the long-term survival. As you can see here, those who underwent surgery after 1 year had a significantly lower survival rate after 20 years. So what are the recommendations? When do we act? For patients who have an RET mutation which has the highest degree, the MEN2B ones, do the total thyroidectomy by age 1. For those who have a high risk of MTC, do total thyroidectomy by age 5. For those who have a moderate risk, either you can choose to do surgery if the parents consent at an earlier age. Otherwise, you can keep monitoring them with serum calcitonin. Once the serum calcitonin shows an increase, that's an indication that you have to do thyroidectomy. Why we are using the last approach or waiting watch approach versus thyroidectomy? Because especially for those patients who have a moderate risk. So there is a risk of converting a normal person into a medically induced disease. So there's a reason why we need to be a little careful about the moderate risk. So only if they have a high risk, they have some manifestation of the disease, it's worth considering them for total thyroidectomy.
Sorry, Dr. Vijay, you have 3 minutes more. Sorry
Okay. 2 minutes more? Okay. So just highlight on the KM experience on pediatric MTC. Again, we found the similar results. So with those who presented by family screening had a better outcome after surgery, whereas those who presented clinically had a poor outcome. So moving on to the two new MEN syndromes, that is MEN4. It's because of mutations in CDKN1B, which codes for P27, which is required for cell regulation. In fact, its manifestations mimic that of MEN1, but however, they're pretty different from that. The penetrance for MEN4 variants is low and a little later, especially for PHPT as well as DP-NETs. However, the prevalence of pituitary tumors is same. There are some pediatric patients also reported. In fact, the youngest patient with MEN4 for PHPT is 15 years, and for pituitary tumor is 5 years. However, there are no pediatric patients with MEN4 who have been reported with DP-NETs. Moving on to the next new syndrome, that's MEN5, that's a MAX mutation, Mike-associated factor X. In fact, it's been known to be associated with PPGL for more than a decade now. But however, its classification into a multiple endocrine neoplasia has occurred just over the last 1 to 2 years. So if you look at the characteristics of PPGL and this MAX-associated disease, majority will have a bilateral adrenal involvement. In fact, 28% are metastatic. And one interesting point about the MAX is, despite it belongs to the cluster 2 of PPGL classification, which typically produce epinephrine, the MAX-associated PPGL produce norepinephrine secreting FIO in 80% of the patients. So why it's called as a MEN5 is basically because of its association, in addition to PPGL, with pituitary adenomas in around 8%, neuroblastomas in around 5%, and also primary hyperparathyroidism in around 4%. So there are many more syndromes which are actually not classified into MEN, but still probably deserve classification as MEN. So due to paucity of time, I won't be able to take them up. To conclude, a high index of suspicion is required to suspect MEN syndromes. Genetic diagnosis of MEN syndromes definitely improves the outcomes. Individual carrying germline variants in MEN1 or any MEN-related genes should be screened for syndrome-specific manifestations as per the recommendations that improves their early diagnosis as well as the long-term outcomes. Thank you so much.
Thank you, Dr. Vijay. Please have your seat on the dais. Meanwhile, Dr. Sylvia will invite the third speaker. Thank you.
So thank you. It is my honor to introduce Professor Hermann Mueller. He is a professor of pediatrics and head of Department of Pediatric Hematology and Oncology at the University Children's Hospital, Karl von Ossietzky, Universität Oldenburg, Klinikum Oldenburg. His interests are listed there. And to speak on craniopharyngiomas, Professor, you have the floor.
Thank you very much for the kind introduction. Dear colleagues, welcome, and I'm happy to present you some of our and others' data on craniopharyngioma, which we have collected over the years. And as I'm a pediatric endocrinologist and oncologist, I will mainly focus on childhood onset craniopharyngioma. As you can see here, and most of you will know this, that about 1.2 to 4.6 of all CNS tumors are craniopharyngioma, 0.5 to 2.5 new cases per 1 million population per year, and 30 to 50% are diagnosed during childhood. 55% of all brain tumors at this age are childhood onset craniopharyngioma. And in childhood and adolescence age group, APC histological type with cyst formation is the most common. PCP papillary type occurs almost only in adults. Oh, I see the fonts of the letters. Okay, that's imaging in craniopharyngioma. And there is a 90% rule which says that in childhood onset craniopharyngioma, 90% of all tumors show calcifications, 90% have cystic compartments, and 90% of tumors have enhancement. When we started many, many years ago, we knew already that many of these patients have severe problems by developing severe obesity, and we wanted to know what the rate of obesity. And we looked at BMI, at diagnosis and yearly intervals after diagnosis in these patients. And what we saw is that approximately half of all patients developed obesity. We saw that in patients developing obesity, the first year after diagnosis and treatment was the time point when the most severe increase in BMI occurred. And what we also found, what was a real surprise for us, is that already at the time of diagnosis, which means before treatment, BMI SDS in patients who developed later on severe obesity was already significantly higher compared to patients who had normal risk. What we did, because we speculated that the mechanisms for developing obesity were already effective at the time of diagnosis, we looked at symptoms and history of our patients, symptoms before the diagnosis of craniopharyngioma. And this graph here shows you the most frequent symptoms, which are headache, visual impairment, growth retardation, neurological symptoms, weight gain, symptoms of diabetes insipidus, and disturbances of pubertal development. What we know is that whatever is noted in the records is biased because many things are not noticed and other things are not mentioned. So we asked the questions whether we have reliable data on the situation before diagnosis. And indeed, in Germany, we have these data based on a national health survey. And in this health survey, each newborn and also during older age is measured. That means height and weight are taken at U1, that's at birth, and you see U2 up to U9, that's the age of 5 years. And what we could do is we could evaluate almost 90 patients according to their growth before and after diagnosis of childhood craniopharyngioma based on this growth charts gathered in health survey. And what you see here is that beginning with U9, with U6, there is a steady and constant decrease in height SDS of these patients. The diagnosis was made at an age of 8 years, and the situation after diagnosis is also shown in yearly intervals. And U6, you have to remember, is at the end of the first year of life, which means that the decrease in height velocity is a really early symptom for diagnosis of craniopharyngioma, at least in this setting. What about the data on weight before and after diagnosis in these patients? Here you see the BMI SDS, once again U1 to U9, diagnosis at 8 years, and then the situation during the yearly follow-up, you know already from a previous slide. What we saw is that the increase in BMI started 2 to 3 years before diagnosis, which means the increase in weight also occurs before diagnosis, but is a rather late symptom in history of these patients. And looking at the same data now for the subgroup of patients without hypothalamic involvement and the patients with hypothalamic involvement, we could see that the development of obesity was actually a problem for patients with hypothalamic obesity. Patients without hypothalamic obesity, they were normal weight before diagnosis, at diagnosis, and they actually kept their normal weight also during follow-up. You see here 2 patients, and the next question is, what happens during long-term follow-up? And you see here once again data you know already. On the right side, there is a steep increase in patients with hypothalamic involvement during the first years. And in this slide, I show you the situation for long-term follow-up for more than 12 years, shown as filled black boxes. And the median follow-up was 16.9 years, ranging from 12 to 36 years. And what you can see is there is no further increase in BMI SDS during long-term follow-up, but the plateau and the stabilizing occurs at a pretty high level of 5 standard deviations, which is severe obesity. Hypothalamic obesity, which is in the background for this development, we know that vagally mediated hyperinsulinemia and autonomic imbalance is a cause, reduced sympathetic tone, reduced sensitivity to endogenous leptin, altered energy expenditure, which is lower in these patients, and other contributing factors such as reduced nocturnal melatonin levels, increased daytime sleepiness, neurological defects, and decreased physical activity, which I will come back to. Oh, there's something missing. That's the recruitment rate of our patients. And as you can see, over many, many years, we have recruited now almost 800 patients who were diagnosed with childhood onset craniopharyngioma. And when you have such a great number of patients, you are able to look at the long-term prognosis and also to make conclusions on the way to treat these patients. And I would like to focus on the patients which are shown here in the middle of the slide in HIT-ENDO that are patients who were diagnosed before the year 2001, 280 patients, and we looked at survival rates of these patients, quality of life and psychosocial status in 108. This slide shows you the 20-year survival rates in these patients, and you see overall survival on the left and progression-free survival on the right side. And we were really surprised to see that in this benign diseases, we have very, very frequent events in terms of death and also progressions, also during long-term follow-up. What's the significance of age at diagnosis? Once again, you see on the right side, the younger patients who were diagnosed at an age younger than 5 years, they had a lower progression-free survival rate, which means this is the age group at diagnosis which has to experience most relapses and recurrences. 20-year survival rates and degree of resection. That's very important because when you look at old textbooks, you find the situation that the authors recommend that's a benign tumor, do a complete resection, cross-total resection, and you have solved the problem. And I can show you here that that's not the case. When you look at the progression-free survival, whether you do complete resection shown as CR or incomplete resection shown as IR, the progression-free survival rates during long-term follow-up are similar. That means limited surgery, preserving critical structures, that there has no harm in terms of a higher frequency of relapses and progressions. And that's also very important. When you look at the same textbooks, they say hypothalamic involvement. Okay, that happens. That's no large problem. But when you look at our data, we could show that actually overall survival is also dependent on the existence of hypothalamic involvement. Patients with hypothalamic involvement had a lower overall survival rate in comparison to patients without hypothalamic involvement. And what were the reasons for death? When you look, 30 patients died, and 28 of these patients had hypothalamic involvement, and almost 25% of these patients died due to, I would say, acute adrenal insufficiency and electrolyte imbalances. And when you look at the high rate of non-documented causes in the lower lane, 34%, I would speculate that many of these patients also had problems in terms of acute adrenal crisis. And we were really surprised that almost all of these patients, as you know, need medication in terms of hormonal substitution, but only 2/3 of them were treated by an endocrinologist. And as in the first column, you see that even almost 10% of patients had no medical attendance at all. Quality of life and psychosocial status. We used the RTC quality of life questionnaire in the MF20. 108 patients were analyzed, and the risk factor we're looking for was hypothalamic involvement. And as you can see at the functioning domains of this score, we saw in patients with hypothalamic involvement, these are the filled boxes, significantly lower self-assessed quality of life in terms of physical functioning. Looking at symptom scale, we saw that on the one side, dyspnea was more frequent in patients with hypothalamic involvement. I think the reason for this is the severe obesity. But we also saw that they had many, many gastrointestinal problems like diarrhea, which was a new finding, which also could be confirmed by the clinical impression treating these patients. Fatigue, MF20 fatigue domains. Here you can see that patients with hypothalamic involvement had significantly increased physical fatigue and also reduced motivation when compared to patients without hypothalamic involvement. And the psychosocial status of these patients, you see here that patients with hypothalamic involvement, pointed out in blue, had a lower rate of partnership and marriages and also a lower rate of driving licenses. That's due to the visual impairment. But we were surprised to see that professional education and employment was not different when compared between patients with hypothalamic involvement and patients without hypothalamic involvement. There are some challenges in treatment because there are different theories. Outcome and development of severe hypothalamic obesity could be related to initial pre-surgical hypothalamic involvement at the time of diagnosis. Or it could be due to hypothalamus-sparing surgical strategies, which means hypothalamic lesions. So what we did is we wanted to know what's the effect of surgical hypothalamic lesions on outcome in craniopharyngioma patients with severe pre-surgical hypothalamic involvement. These are these worst case patients who have involvement of the hypothalamus. And in order to understand our grading system, you have to be aware that's the hypothalamus, the stalk, and the pituitary. And in our grading system, we have to identify the mammillary bodies. Whenever the tumor or the lesion involves the mammillary bodies and the area posterior, we call it posterior involvement or lesion. All other lesions anterior or no lesion. And here you see three cases. On the upper level, you have a case anterior and posterior hypothalamic involvement, worst case. But in this case, the surgery was only a drainage of the cyst, which resulted in no hypothalamic lesion. That's grade 0. And the second line is also anterior posterior hypothalamic involvement, but only an anterior part of the tumor compartment was resected, resulting in anterior hypothalamic lesions. And on the third lower row, also anterior posterior hypothalamic involvement. And in this case, in this worst case, the complete tumor was resected, leading to anterior and posterior hypothalamic lesions. And we were able to analyze 109 patients who all had severe hypothalamic involvement before surgery, and they were treated differently in a way that 35% had 21% had surgical anterior lesions, 27% had 21% had no hypothalamic lesions, 27% had anterior hypothalamic lesions, and 52% had anterior and posterior hypothalamic lesions. And we looked at overall survival rates, BMI, quality of life. And the cohorts were comparable in these terms of age diagnosis, gender, and tumor size. And we looked at progression-free survival with regard to different ways to treat these patients, and we saw there was no difference. But looking at the development of BMI, there were severe differences. On the left, you see the patients, all these patients had severe involvement of the hypothalamus, but on the left side, you see the development for patients without surgical hypothalamic lesion. In the middle box is anterior hypothalamic lesion, and on the right side, anterior and posterior hypothalamic lesions. The open boxes is the situation at diagnosis, and then further on during yearly follow-ups. And as you can see on the left hand, patients with anterior and posterior hypothalamic lesions had the most severe increase of BMI SDS during the first year after treatment. Also in the other cases you see, in cases without hypothalamic lesion and anterior lesion, they have a certain increase in BMI SDS, but this is not that severe and that impressive. And looking at the same patients for the quality of life with regard to these hypothalamic lesions, it's a complicated slide. On A and B, you see the self-assessment. On C and D, that's parental assessment. A and C is the first year. There is no difference. But after 3 years, you see that especially patients with anterior and posterior hypothalamic surgical lesions, they have a self-assessment of significantly lower quality of life for body image, for autonomy, for physical function, and also for social function. Many of these patients have to undergo surgery, and only in a few of them the tumor can be resected. And here you see on the right side, that's a completely resected tumor. You see the optic nerve, which is bending, and in the middle of it, you see the pituitary stalk, which could be preserved in these patients. But in many of these patients, you have the situation that they have cystic compartments, which you can hardly resect. And in these patients, you have to mainly insert a catheter to diminish the intracystic pressure. And you have the opportunity to install chemotherapeutic agents to treat the epithelium, which produces the fluid, which in events increases the pressure. And for this treatment, intracavitary interferon alpha was invented. That's a Toronto schedule to apply this substance 3 times a week for 4 weeks, 3 million units per installation. And this works pretty well. It shows that the time to disease progression for only cystic tumors could be prolonged in patients who had a majority of solid tumors. This medication of intracavitary treatment did not diminish the solid parts of the tumor. And it did not lead to any decrease in quality of life or clinical situation. In some of these patients, the situation even improved. But it's a pity. Interferon alpha is currently not available on the market for this indication. But currently, PEG interferon is tested as an alternative for intracavitary treatment. Irradiation is it's very important to have this method to treat these patients, and we nowadays prefer to do proton beam irradiation. On the upper two graphs, you can see that the field of irradiation can be more precisely described and touched by this kind of proton beam irradiation due to the physical abilities. And this graph here shows you the progression-free survival of patients with immediate irradiation on the upper solid line after incomplete resection, and progression-free survival of patients with irradiation at the time of progression. And as you can see, this immediate postoperative irradiation is highly efficient in preventing relapses. And I have to say that patients on this graph who experienced relapses, they could be salvaged by doing the irradiation then later on. Obesity, nutrition, and physical activity. We looked at energy intake, and we could find no difference using nutritional diaries between patients with intracellular craniopharyngioma, hypothalamic craniopharyngioma, and healthy controls. That was a surprise, but these findings were confirmed in many studies also of other groups. And we looked at activity using accelerometry, and there we found that especially during leisure time, and all the patients and controls were in an indoor setting for doing rehabilitation, that during leisure time the activity of the craniopharyngioma patients was decreased when compared to BMI-matched healthy controls. And when you ask these patients, they tell you that during daytime they are really sleepy and during nighttime they cannot sleep. So we speculated that maybe melatonin production might have an effect. Melatonin is produced in the pineal gland and is secreted over the hypothalamus. And then we looked at nighttime and morning production of melatonin in saliva. And what we could show is that in craniopharyngioma patients and hypothalamic astrocytoma patients, especially in patients with a high BMI, these are the open boxes, they have a significantly lower melatonin concentration in saliva at nighttime as well as in the morning when compared to BMI-matched healthy controls. And when you have such disturbances of circadian rhythm, you do a polysomnography. We did this. And actually what we expected was an obstructive sleep apnea because many of these patients were really obese. And we were surprised to see that many of them had hypersomnia and 4 of them had secondary narcolepsy. That's a finding which is related to typical sleep onset REM phases that were detected in these patients. And this secondary narcolepsy is treated by central stimulating agents, and we did this and improved their daytime sleepiness. Bariatric surgery, most efficient are bypass surgery. However, as you can imagine in pediatric cohorts, such non-reversible techniques are controversial due to legal and ethical considerations. Obesity medication, these are a lot of chemical agents, anti-diabetic stimulants and other agents. However, I have to say that many of them have not been proven in randomized trials. And perhaps 2 glucagon-like protein 1 receptor, GLP-1 receptor agonists, that's semaglutide, which has recently very good effectiveness and shown tolerability, and also alpha-MSH receptor agonist as setmelanotide. We have seen very good results in a phase 1-2 trial, and currently there's a phase 3 trial in patients with acquired hypothalamic obesity. Systemic chemotherapy, I think most of you will think, what's that? That's a benign tumor. How and why do chemotherapy? But indeed, it was done many, many years ago, but it was not followed up because it's not a non-malignant tumor, and cytotoxic effects have no curable, are not curable in these patients. But there was recently a publication in the New England Journal of Medicine reporting on BRAF/MEK inhibition of newly diagnosed patients with papillary craniopharyngiomas. And indeed, this MEK inhibition based on targeted therapy is highly efficient in these patients. As you can see here in panels A, B, and C, that's a follow-up in a patient who was treated with this medication. This works only in patients with BRAF mutations, which can be accounted in a high percentage in adult onset craniopharyngioma, but which is not detectable in the childhood onset craniopharyngioma. You see, it's most of the patients had a significant change in tumor volume, except of one patient, and it was very well tolerated. Okay, in childhood onset patients with craniopharyngioma, you see we have several ways to think about doing chemotherapy in these patients. And actually, there's currently a trial, Connect on 2108. This is a phase 2 study of the MEK inhibitor, MEKTOVI, for the treatment of progressive and recurrent pediatric craniopharyngioma. You see the inclusion criteria, 12 months to 25 years, histologically confirmed, must have recovered or stabilized from the acute toxic effects of prior treatments, and must have an adequate organ function. That's an ongoing trial. And also a second agent, that's tocilizumab, which many of you might know from treatment of arthritis in pediatric cohort. That's a humanized monoclonal antibody which acts against soluble and membrane-bound IL-6 receptors. And you see below the curves for the tumor volume under treatment for 2 cases. And also this agent is currently tested in a trial, Connect 1905. Study design, and the hypothesis is single agent tocilizumab will be safe and effective at inducing tumor response in children with residual childhood onset craniopharyngioma. Is a multicenter single agent trial. And stratum 1, patients with progressive or recurrent ACP following irradiation. Stratum 2 is patients with progressive, unresectable or recurrent ACP treated with at least surgery who have not previously received irradiation. And last not least, there is a PNOC trial, PNOC 029 trial, which uses nivolumab on day 101 for the treatment of newly diagnosed or recurrent craniopharyngioma in children and young adults. Day 101 is a pan-RAF kinase inhibitor which inhibits BRAF V600 and BRAF fusion alterations. Significantly greater CNS penetrations was observed than in other available type 1 inhibitors, and it's given weekly instead of daily. Nivolumab is a PD-1 receptor inhibitor, monoclonal antibody, and PD-L1 expression is found in CP cyst epithelia, and the PD-1 expression is even higher than in medulloblastoma. And the combination of nivolumab and day 101 shows that we all hope that there are direct effects on tumor cell growth. It's open in the US, but it's difficult. They have only recruited up to 6 patients now, and it's also difficult to open this trial in Europe, especially in Germany, because due to legal considerations. And there is also one thing which is interesting, which can be discussed. When you have a situation, and I think that's a rare situation, you have a newly diagnosed patient with craniopharyngioma, the 90% rule is found, the imaging says that's a craniopharyngioma, and all other markers say that's a craniopharyngioma, then this medication can be chosen for treatment before operation, before resection, before biopsy, and then after having a certain time for this medication to work, then the surgery is done, and in a histological analysis, they want to prove the effects of nivolumab and day 101. So I come to my conclusions. Childhood onset craniopharyngioma, I think you should know that decreased growth rates are an early symptom the combination between growth retardation, headache, and vision should lead to suspicion to craniopharyngioma. Treatment should also always focus on hypothalamus sparing strategies. Irradiation of progressive residual tumor, especially with proton beam therapy, is effective and actually very well tolerated. Prognosis is impaired due to sequelae, especially hypothalamic obesity, and further research on targeted therapy and treatment of hypothalamic obesity is warranted. And the treatment should also be always be planned by a multidisciplinary experienced team. And the next talk and the next chapter is hypothalamic syndrome, which is characterized by intractable weight gain associated with severe morbid obesity, multiple endocrine abnormalities, and memory impairment, attention deficit, and reduced impulse control, as well as increased risk of cardiovascular and metabolic disorders. And craniopharyngioma is part of this hypothalamic syndrome, but many other diseases are also come to this final diagnosis of hypothalamic syndrome. And nowadays we are doing research in defining this syndrome and looking at ways to treat it. Thank you for your kind attention.
Thank you very much for your overview. Very interesting and hopeful for our cancer patients. So the floor is now open for your questions.
That's better. Thank you. Paul Hoffman, New Zealand. I have two questions, if that's okay. The first to Professor Mueller. Proton beam radiation for craniopharyngioma has, I think, been a fantastic benefit to children in terms of reducing their morbidity. Do you delay therapy? Because we did delay radiotherapy in the past until younger children were older to try and reduce that morbidity. Is your unit now using this therapy earlier, or do you have any data on that?
Yeah, I think the times are changing. When I started, we also tried to postpone irradiation later on. But nowadays, with this new and novel techniques, with better anesthesia, with better planning, imaging, we would tend not to wait too long when we see that the tumor is progressive. We have patients, they had surgery for 8 times and then irradiation was done. And now after 20, 30 years, everybody thinks these patients should have been irradiated much more earlier, and then their outcome would have been better.
Great. And Wasim, can I just ask about the growth hormone recurrence from the same tumor, which is no different with growth hormone, but in terms of making you feel more comfortable, is there any benefit of looking for growth hormone receptors on those tumors? And if they're negative, does that reduce the risk, or do you have any information on that?
So I'm really not so sure that we are at that level in terms of being able to identify receptors to growth hormone, but it could be one of the keys, because a lot of the effects in the in vitro models and animal models have been independent of the presence, or this was not documented in. So it's a very good question. I'm really not sure of the answer and the practicability. I don't know if Herman, you know anything about it?
We did this analysis years ago in some of the tumors, and as expected, they have receptors. Any other thing would have been a surprise. But what we also did, we looked at the effect of growth hormone treatment in a large cohort, which we took care of, and we saw, first of all, the recurrence and progression rate is high, and secondly, it is not related and associated with growth hormone substitution. And the timing of initiation of growth hormone, as Wasim already told, we are flexible. I think 3 months after surgery is for a craniopharyngioma patient. They get surgery and the next day everything changed. They have panhypopituitarism, which means the family and the patient have to be accustomed to so many medications, so that we say first get this managed. And then later on, when the tumor is stable, when you don't need irradiation, then we can think about substituting growth hormone. It's similar to sex steroids. You would never substitute sex steroids in the first week after surgery. That has time, and that should be done when every other thing is settled.
Margaret Zachrin, Australia. Dr. Shimati, In relation to the newer treatments for gliomas, particularly using checkpoint inhibitors and immunomodulators, firstly, they cause catastrophic growth failure, and secondly, there appears probably to be no fixed endpoint to their intervention. What do you think about the use of growth hormone for children under these circumstances?
So in theory, active tumor growth or requirement for medication to stop tumor growth is a contraindication for treatment with growth hormone. But the reality is that in many instances I've heard of, it's not something that I've personally experienced as a provider. There are more and more decision-making conversations with the patients, with the families, and with the oncologists as we try and get more experience in this field. So I am aware that in a subset of cases where there is really severe growth impairment and where there is continuous treatment with really no end in sight, I've seen colleagues in endocrinology prescribe growth hormone, all while making sure that IGF-1 levels are not increased above the normal range, all making sure that it's making a difference and it's resulting in improvement while continuing the conversations with the oncologist. So I think this is an active area of research. Most of the patients I've seen on tyrosine kinase inhibitors or immunomodulators were actually taken off of these medications after a certain time. I don't have experience of prescribing it concurrently. This is not something that I have first experience in.
Thank you, Professor Vasam. So you mentioned the restricting the use of growth hormone in children with the risk for high tumors like chromosomal breakage syndromes. But would you suggest holding back on growth hormone in certain other syndromes like Kabuki or Malibre nanism? Would you still restrict growth hormone in those situations also, or would you mean only chromosomal breakage syndromes?
So all the Growth Hormone Research Society really suggests caution in these patients in general, making sure that they are growth hormone deficient before prescribing it. And this really reduces your pool drastically, because in many of these instances, children are not growth hormone deficient. And in which case, really, the use of growth hormone for height augmentation is contraindicated, especially that we are really not sure of benefit. So I tend to be very conservative in these cases. But then again, I've seen colleagues treat a subset of these patients after long conversations with the geneticists, with the families. So I think it also goes down to case by case. But the consensus among experts has been to be extremely careful in these instances and to not give growth hormone unless we see growth hormone deficiency.
Thank you. Vijay Sarthi, just a question to you. So would you check for calcitonin as a baseline value, or would you use a pentagastrin test to measure calcitonin?
It's mostly basal level, ma'am. So we don't do pentagastrin stimulation. Even if we had to do in some patients, in adults actually, we did a calcium stimulation. Pentagastrin is not available to use as a test currently in India. But most of the situations, you don't require a stimulation test at all. Basal calcitonin is a good test now.
Miller from Minnesota for Professor Shamatili. My question was defining growth hormone deficiency in some of the children who've had hypothalamic radiation. What do you end up using to make that diagnosis? We have a few children who have what appears to be a normal growth hormone stimulation result, but very low IGF-1 levels that we think is related to the radiation.
So we use for diagnosing the growth hormone, the Endocrine Society guidelines for the diagnosis of growth hormone deficiency. The recommendation is to use dynamic testing using two different agents like we would do in other pediatric populations, except that we do, you should not use GHRH because the site of the deficit is often hypothalamic in relation to radiation. I must say that the issue with IGF-1 is often that IGF-1 is normal or borderline low while patients fail growth hormone testing. I really never recall instances other where the child had low IGF-1 with normal stim test and where this was not related to some nutritional issue or some confounding factor. Growth hormone dynamic testing tends to have quite a few pitfalls in the context of diagnosing idiopathic growth hormone deficiency, I will say that very high probability, pre-testing probability is such in our population that this is really rarely an issue. So really the recommendation is to use dynamic testing in these patients. And the problem is more often than not the use of IGF-1 resulting in overdiagnosing growth hormone deficiency in this population.
Thank you.
Wayne Cutfield, New Zealand. Firstly, I'd like to thank all three of you for three outstanding presentations. And for those delegates who peeled off early in the afternoon, they missed out. So thank you. Two quick questions. Firstly, to you, Wasim, and it's sort of an extension of Paul Hoffman's question. Do you think there could be a time, given that there is still somewhat muddy data on second tumour risks and recurrences, or occurrence of second tumours, that we will use whole exome sequencing or panels for tumour suppressor gene mutations to try and help thread through what those risks are? As you've commented, that we don't have a good control group, and follow-up, we really need 40 or 50 or 60 years of follow-up to really understand whole-of-life risk. So what do you envisage that we'll be able to add in some more tools to look at a second tumour occurrence risk,
So I really think the problem of second tumors, the biggest difficulty is that it is a risk that's already very tightly related to radiation or to genetic factors. The association with these factors are so strong that it's very, very difficult to establish that growth hormone really plays a role. And so I don't know, I think as we think of precision medicine, it's definitely very attractive, what you are proposing. I'm just not really sure that it can get us outside of how predominant the effect really is of other risk factors compared to presumed risk of growth hormone in these instances.
Okay, thank you. Herman, a quick question for you. When you were comparing with and without hypothalamic involvement in surgery, I'm sure you've analysed the additional impact of radiotherapy to try and tease out how much of it is hypothalamic involvement and how much of it is radiotherapy. I would suspect that there's a greater likelihood of radiotherapy with hypothalamic involvement unless you're giving radiotherapy to all of your patients.
I think the effect of surgery is much more direct, and you can experience almost the day after surgery, whereas the effect of irradiation, proton or photon, takes many years to become apparent and really effective. So it's difficult to answer that question of specific effects, because usually you need longer follow-up.
Wonderful talks. This is Dr. Wasim. Yeah, I just want to know one thing. So we have a patient of craniopharyngioma. We have started treatment after 6-9 months, and it recurs again. So will we stop the growth hormone, or we just continue the growth hormone?
So, Herman, so I think the question is, so there's a patient with craniopharyngioma who experienced a recurrence fairly quickly after starting growth hormone. I would say that it is very unlikely that growth hormone played a role in the recurrence of craniopharyngioma in this patient.
So just continue the treatment.
So what I would do is generally I stop the growth hormone until the tumor is treated and cured, and then 3 to 6 months later, if the tumor is stable, has been treated, and the oncologist or the radiation oncologist or the neurosurgeons are okay with it, and if the family approves as well as the patient, some of them have some PTSD and they want to wait a little bit longer, and that's okay. So I wouldn't say never retreat a patient who had a recurrence with growth hormone, because again, the association is only hypothetical. There are so many other factors that are at play. And I work with every family based on their comfort level with these discussions. Some family would not want growth hormone to be stopped at all. Some families would not want their child to ever have to take growth hormone again. And there's everything in between where they want you to wait a little bit. And I think it's really important to individualize. And I'm sure that Herman has also a lot of experience.
Yeah, I agree.
So Vijay, one question, we get a lot of patients with high prolactins, and we start them cabergoline. So which are the group of patients we should start thinking of? Men, if we have high prolactin, and or what are the issues should we look for for those to do a further work on men?
I think so. It's worth running one serum calcium for all patients with pediatric prolactinoma. So if calcium is usually, since it's a disease which has the highest penetrance among the men one, so if calcium is elevated or even high normal, so probably that's the cohort we should go with men one mutations.
Yeah, my question is to the Vijay sir for the main one management. So, which therapy would be better for the pediatric adolescent age group who has a PNETs? Either they have to go for the sandostatin or lutetium-based nucleotherapy. If they want to go for the second questions, if they want to go for the sandostatin, then what is your experience regarding that?
See, sandostatin is used as a second line or the third line management for PNET. The first line of treatment is always the excision because most of them are amenable for surgery. So obviously the functional tumors, so they have to be excised irrespective of the size. For the non-functional tumors, we reserve to excision only for tumors which are more than 2 to 3 centimeter. There are tumors which are already metastatic with or an inoperable disease. There comes a question whether you have to go for somatostatin analog therapy or a PRRT. So for a diffuse metastatic disease, obviously PRRT is a preferred choice. But a localized inoperable disease, so especially functional ones, you can always give a trial of sandostatin or the somatostatin analog therapy.
So if tumor is there and it is multiple tumor is there, so surgery could be the not good options for that. In perspective, sandostatin would be better.
So if it's a like non-functional tumors less than 2 centimeter, even if they're multiple, I need not have to treat them. So, but if it's a functional tumor, if there are multiple, so if it's probably all the lesions are located in a distal pancreas or like that, even considering a distal pancreatectomy is easy. But if at all, if we have like multiple small gastrinomas, in fact, this task comes in gastrinomas. Fortunately, the gastrinomas are not so prevalent in pediatric age group. But if you have a young adult with a gastrinoma, and if that's not an inoperable disease, and it's not a metastatic disease, it responds well to octreotide.
Thank you very much.
Sake of time, we'll have one more question, please. Yeah.
My question is for Dr. Muller, and it relates to a recurrent craniopharyngioma and radiation. Supposing we have a child in the mid-childhood age group, and as you and Dr. Hoffman said, the times are changing and radiation therapy is considered earlier and earlier now, not delayed. So supposing we have like a 5-6-year-old child, and in follow-up after the first surgery, there is a progression of the tumor, of a residual tumor, and it's not near the optic apparatus. Would we go for a second surgery and then wait for further increase of a residual lesion, or would we give radiation only, or would we give radiation and go for a second surgery? I'm specifically talking about mid-childhood age group because we used to avoid early radiation for these children.
What we do is we look exactly whether the tumor or the progression relapse involves the hypothalamus and whether there are critical structures which should prevent a further surgical approach. If the neurosurgeon says, I can remove part of it, but the rest of the tumor still remains in the hypothalamus, then you can speculate that that rest of tumor after surgery will grow again and you will have the same situation half a year later. So in this situation, we say, okay, at that age, we would do irradiation, a good planning, a very good technique, and then we are confident that that's the better choice than to do a surgery which endangers the hypothalamic integrity. And a similar decision should be made when the tumor involves or compresses the optic nerve or so. You can do it, but when the surgeon says, I will do harm, then you should stop and choose other devices.
Thank you. Thank you, everyone, for the active participation. And with this, we come to the close of this session. This session, I must say, was full of first-hand, vast experience by the experts themselves in the field. Thank you very much, all the speakers.
I thank the speakers for their enlightening talks and sharing their experience with us. And I thank the chairpersons for guiding us through the session. I would now request Dr. Sudha Rao and Dr. Vandana Jain to please felicitate our speakers and chairpersons, and Dr. Anjali to kindly accompany them. At the felicitation point, just outside the room. Just a small announcement, the posters are on display in the foyer, and please have a look at them and encourage our young investigators. In about 5 to 10 minutes, we'll have the automated insulin delivery workshop right here. So just for after a quick cup of tea, you can please assemble here back again. Thank you.
I request everybody to kindly stay back for a really enriching session on automated insulin delivery and advanced hybrid loop closed system technology. This is being conducted by the Medtronic teams, but we have wonderful esteemed